All right, Sarah, I think I'll get started in the interest of time. My name is Jessica Posner, and I am with JSI. And on behalf of PATH and Friends of the Global Fight and JSI, we would like to welcome you to this session, which is titled Pathway to Universal Health Coverage, Scaling Integrated Person-Centered Care in the HIV Response and Beyond. So to help orient us before we dive into this rich discussion, let me provide a little bit of context as to why these three organizations came together to examine this specific set of issues. Our organizations, in different ways, do a lot of work in the HIV space, and we have a real recognition and appreciation for the paramount role that integrated person-centered care has played in the success of the HIV response. The response has been able to reach a diverse set of people and work in diverse health settings. Integrated person-centered care really is an approach to health services that puts people and their communities at the center of the health system and empowers them to take charge of their own health. And evidence underscores that when adequately financed and done well, it doesn't only increase client satisfaction, but increases health utilization as well as health outcomes. At the same time, we also recognize that, as others have so aptly said, what got us here might not get us there, or get us where we want to go. There has been a stall in the progress in the HIV response, and we are failing to reach and sometimes support some of the most vulnerable. And then concurrently, we have universal health coverage movement, which all three organizations deeply believe in, and we work in various ways to support countries' commitment to reach these goals. So shortly after the Montreal AIDS conference in 2022, we came together around these topics, wanting to better articulate the connections between integrated person-centered care, the HIV response, what worked, what didn't, and what we can really do to learn and apply this to reaching universal health coverage. We realized that across our organizations, we really were connected in some form or fashion to some really valuable stakeholders, some of whom you will hear from today. And so we really wanted to leverage that our collective experience, your collective experience, our stakeholders' experiences and networks, and really add to this growing evidence base and support the movement to both reinvigorate the HIV response and to continue to support universal health coverage by 2023. So what you'll get from us is some broad strokes findings and lessons learned, and then what we hope will be a really rich panel discussion with some of our stakeholders. So without further ado, here is Davina Kanagasave to give us some overview, some broad strokes. Over to you, Davina.
Thank you, Jessica, and hello, everyone. I am delighted to be here on behalf of PATH, Friends, and JSI to present highlights from our recent report looking at the potential of integrated person-centered care, IPCC, as a pathway to getting us to universal health coverage. Next slide, please. So stemming from the recognition that people need to be at the forefront of health service delivery, IPCC has emerged over the past few years in the HIV response as an approach to deliver accessible, comprehensive, and coordinated services that align with individual preferences and values. And with primary health care as a platform around which to build towards sustainable health systems, people-centered care has been further elevated as the mechanism to foster integration to get us to 2030 HIV, pandemic preparedness, and UHC goals. So building on this momentum, and as Jessica just mentioned, we embarked on a study to explore how IPCC is being used in the HIV response and what else needs to be done to build on these models to broaden access to health and other services as part of expanded and strengthened PHC systems. To answer these questions, we undertook a desk review and held consultations with a range of stakeholders from representatives of funding and normative agencies to implementers, advocates, and clients. Next slide, please. So what have we learned so far from applying IPCC in HIV? Well, first, that HIV has contributed to advancing health integration bidirectionally. And our research and consultations pointed to many examples, both of other health services being integrated into the HIV platform. For example, sexual health, mental health, and viral hepatitis being incorporated into core packages for people living with or affected by HIV. And vice versa, building HIV services into PHC and other health platforms. So integrating HIV screening, care, and prevention at family planning clinics, or as a part of care for non-communicable diseases like hypertension. Second is that IPCC models come in all shapes and sizes, so very much upholds the principles of differentiated service delivery by giving clients choice in how, where, from whom, and when to receive the services they need to ensure their overall health and well-being. This lesson is also driven in part by some caution that we heard in our consultations that promoting integration solely within public sector entities may not work for all populations. And so moving forward, also equally ensuring that integration continues to be advanced and sustained in specialized community, peer-driven, and private sector delivery channels that may be preferred by key priority and other populations. And finally, the literature, as well as our results from implementation, clearly show that promoting more convenient health services through integrated models, whether that be one-stop shops and decentralized or virtual service delivery, to use of integrated point-of-care diagnostics and digital tools, does indeed lead to improved health outcomes. Next slide, please. And so with that, how should IPCC be scaled up moving forward? Well, there's still work to be done to make IPCC standard practice within the HIV response as well as NPHC, and most urgently for prevention and comorbidities. And as part of this, continuing to push the bounds on exploring services across health areas that can be packaged together in an acceptable, feasible, affordable, and impactful manner. But scaling IPCC across both the HIV and PHC platforms also needs to be done in a stepwise manner to ensure that we're simultaneously considering and addressing core systems issues that are critical to long-term sustainability, particularly financing and health workforce development, and especially for DST and other models outside of the public sector delivery points. Taking a stepwise approach to integration also requires developing indicators for IPCC and strengthening monitoring systems that can generate data to inform further expansion and accountability to scale IPCC. Monitoring IPCC also requires further advancing community-led monitoring and feedback mechanisms to elicit perspectives from clients and providers to ensure that we're not moving integration so far or too fast as to impact service quality. Next slide, please. So as we move forward with scaling IPCC across HIV and PHC, what are 3 things we need to do now to fully realize the potential of IPCC? So first is making a concerted and sustained investment to adequately prepare, train, equip, and support the health workforce needed to deliver IPCC. Second is setting up systems to continuously monitor and improve the quality, fit, and impact of HIV and PHC services, while making space for inclusive citizen engagement in demanding IPCC. And finally, and most critically to us, is standardizing community involvement in healthcare. Communities are essential partners in IPCC and play a unique role as liaisons and counterpoint to facility-based cadres in delivering inclusive and responsive health services. And so we need to recognize, formalize, and compensate communities for the role they have and will continue to play in getting us to ending AIDS as a public health threat and achieving health for all. Next slide. And so to close, I just want to acknowledge my colleagues at PATH, Friends, and JSI, as well as thank everyone who participated in our stakeholder consultations for their time and perspectives. Please do check out our report for further insights on IPCC as a pathway to UHC, as well as for some examples of IPCC in action. With that, I will now turn it over to Dr. Kimberly Green, PATH's Global Director for Primary Healthcare, to delve deeper into some of these issues with our panel. Thank you, and over to you, Dr. Green.
Thank you so much, Davina. Thank you for your brilliant framing of the work and of IPCC. So now it's my honor to introduce a stellar panel of individuals who are each leaders in different aspects of HIV, integration, health systems, and who will be providing thoughts on why integration matters and where they think HIV programs need to head to ensure they are sustained and of quality. So first, I'd like to introduce Diana Freimas, who's the Global Health Workforce Coordinator and Branch Chief at USAID, and she also led the first year of Primary Impact, which you'll hear more about very soon. I'd also like to welcome Dr. Salim Hussain, Deputy Director of Medical Services and Head of Primary Healthcare, Ministry of Health, Kenya, who is leading some very innovative and exciting primary healthcare initiatives, including those that focus on integrated people-centered care. And next, I'd like to welcome Lillian Mareko, who is phenomenal Executive Director of the International Community of Women Living with HIV, the East Africa chapter. And next, Danvik Rosadinho, who is the Head of Programs and Innovations for an organization that you will love called Love Yourself. And then finally, Dr. Mukta Sharma, who is the cross-cutting lead for HIV at the World Health Organization and is doing some really interesting thinking about HIV and sustainability. So before we start with the panel discussion, just wanted to remind all of the audience that you're very welcome to post questions in the chat to the panelists at any time. At the very end of our discussion, we will have time to get to a few of those questions. So with that, I'd like to start first with you, Mukta. And Mukta, would love it if you're able to come on camera.
It says I cannot start my video because the host has stopped it. Ah, yeah, okay. Can you see me now?
I can see your beautiful face, yes, perfect.
Thank you so much for the warm welcome and really happy to be here.
Excellent. So Mukta, since Alma Ata, WHO has led on numerous advancements in and guidance on integrated people-centered primary healthcare as the cornerstone of reaching universal health coverage equitably and sustainably. And related to this, last year published a really helpful think piece on PHC and HIV policy considerations for decision makers. So now, with a finite fiscal space for health, where do you see opportunities for optimal integration of HIV as part of primary healthcare while retaining quality of HIV care and people-centered approaches? Over to you.
Thank you. So first of all, a big thanks from me to all of you who have organized this really important conversation. This is a conversation that is happening everywhere at the moment, and there are no fixed answers that are applicable everywhere. But let me just share my perspective on it, and I'm sure that in the conversation with others, my perspective will also develop. Let me just state first that integration is a means to an end. It is not something that we need to do in itself. And we do it for 4 reasons. We do it for efficiency, we do it for equity, we do it for better effectiveness and responsiveness. The second point I want to make is that resources are always finite. And so I don't think that there was ever any question that we would be able to do integration without resources. What is important is we do things in a way that is efficient. And if there are member states, that's what we call them in WHO, who are still not investing in health or are investing too little in health, then the first message there really is that basic level of investment has to be there, because you cannot integrate into nothing. Now, coming back to integration, I think it's important to understand also that integration is not just of HIV into existing programs, but also to recognize that in many parts of the world, the HIV model has been the only chronic care model. And in fact, it may be important for other programs to use that as a stepping stone to provide long-term care for NCDs, for cancer, for pain management to the community. So it goes both ways. Now, you've been so kind and you've already highlighted our guidance, our recent guidance on I don't know if you can see this. It looks a bit hazy, but this is our recent guidance on primary health care and HIV. We call it convergent actions. And what we're trying to do here is to put some reflections out there for policymakers to help them to think about how we can optimize and synergize better between the existing resources, assets that we have in the health system, the future ones that are being planned for both supporting PHC better, but also disease-specific programs. And this is not just valid for HIV. We're talking about HIV, but you could say the same thing for TB and various other conditions. So the framework is really based on a theory of change, and it's describing how the core elements of PHC, the PHC approach, can be operationalized in 14 domains. And these domains link from governance to financing to purchasing and payment types to service delivery models, monitoring and evaluation, how you engage the community, et cetera, et cetera. So now you've asked me this question of where are the opportunities? So taking a look at the science, what do we know at the moment? We know there is evidence that integration has worked very well for HIV/TB. It's worked really well, or it should work really well if everybody does their job. It's worked really well in the areas of sexual health, family planning, MCH, mental health, non-communicable diseases. But there are areas where we're concerned that there may be challenges. For example, key populations, people who inject drugs, men who have sex with men, in areas that are highly stigmatized. Are there ways that we need to protect these populations and services for these populations? And, we might think about integration as a longer term goal there while we are able to get these things going. So I think it's important to recognize that not everything can be integrated everywhere at the same time. Context, the readiness of the health system, and the understanding within the health system and the disease-specific programs of what needs to be changed and where that willingness for change management comes in is very important. At WHO, we have some tools. We have something called the cross-programmatic efficiency analysis. And this is a really important tool that helps you to think about not the disease-specific components, but the other cross-cutting services that could be integrated. So here I'm thinking about supply chains, IT systems, training, procurement, public financial management. There's no reason why we should have these for HIV separately, TB separately, malaria separately. So these can really be integrated straight away if we think about it clearly. Now, if you come to the disease-specific aspect of this, we've got 2-3 really interesting things happening even in low and middle income countries at the moment. The first is every country I go to now, currently I'm in Africa, and I'm really surprised that so many countries now are setting up social health security funded schemes. And if you start thinking really early enough to say, what can be put in the package? How can that package be defined? And having a really clear sense of how you define that package, that is a huge opportunity in many places. If you think about countries like Thailand, this has been integrated into the health security package for a long time ago. Very, very, very comprehensive package. But in other countries, you could start thinking about integrating HIV testing, for example, into MCH, or you could start thinking about social contracting from universal health coverage funded schemes for KP services. India has done that for a long time. So there's plenty of opportunities, but the key here is to remember there are 3 questions you always have to ask. How does integration affect the coverage of services? Is it going to reduce it? Is it going to increase it? And you have to be really, really clear about that. Secondly, will it be effective? What will the cost be? And when we are thinking about cost, to recognize that it's really, really important to focus on the outcome. If the outcome is less services, less effective services, more stigmatized services, that's not an outcome we want. So the outcome is still where we need to be focused on. Maybe I'll stop because, maybe other panel members have much more to say on this as well.
Thanks, Mukta. Brilliant, very practical, useful considerations related to integration. I really liked, your point about it's not one size fits all. It's really just about what works best in different contexts and for different populations. I like the fact that you talked about it's not integrating one into the other. There's so much to be learned from HIV with the chronic disease management model. And equally, there's benefits for people living with and affected by HIV to be able to access other healthcare services through primary healthcare. And you touched upon quality and specifically key populations and where it's really important to be very careful in thinking through how to integrate and how to ensure that rights and the quality of care is protected. And so then related to that, Danvik, I want to turn to you. So Danvik, Love Yourself has been at the vanguard of delivering comprehensive community-led HIV and primary healthcare services that respond to a range of key populations, needs, and preferences. Tell us more about why community-led services were needed in the Philippines, why you started off with a more comprehensive approach rather than starting with just specific HIV services, and what would you recommend to other community groups wanting to do the same? Over to you.
Thank you so much, Kim. I would like to thank the organizers of this webinar for having to share how we reached where we are today as an organization. And it's such a funny question, Kim, because I think if we started to realize, if we really know as an organization where we would want to go in terms of how do we serve the community, and if we started off right from the start where we needed to go, I think it would have saved a lot of time for us, learning a lot. And I think we started as an organization just providing HIV testing services. From that time, we just wanted to serve people, meaning Love Yourself started an organization with just 6 people wanting to lead our friends where we would want to access services, because back then, we didn't know where to go. And basically from that concept of just helping our friends, it expanded to offering HIV testing services to more members of the key population. So that involves as we reach out to key populations, of course, the questions now appear like, how do we make our services more accessible to key populations? How do we ensure that the messaging, the demand generation, the key messages that we share to the communities are acceptable to them? It's free from stigma and discrimination. So it really, demand generation is even also part of service delivery. As we generate demand, we ensure that these services are fit for the key populations that we want to reach. So from HIV testing, we then now stress the importance of needing more services. So, from HIV testing, where we say, oh, people are now getting reactive for HIV tests. Now, where do we access confirmatory testing? So I think we should access confirmatory testing. We don't have a space to house all of this, so I think we should establish a community center. So from the key populations that we reach, we recognize that, our approach for gay, bisexual, and men who have sex with men might not work for transgender women. So I think we should integrate transgender health services. And as we expand more with our treatment program, with our offering of prevention services, we now have a stress of importance of, wait a minute, I think we should also introduce mental health services. So from that point of just offering testing alone, it expanded to where Love Yourself is right now as an organization that really provides sexual health, transgender health, and mental health services for the community. I think as a community-based organization with that sole desire of, making our services accessible and reachable to key populations, I think that started out as our anchor in terms of how do we expand our services and how do we make our services integrated in such a way that when a member of the key population comes in and entrusted us with their care to us, then they're there already. So we, as much as possible, we will provide all of the services that we could provide to the client and make sure that that is a safe space for them to access the service and access as many services as possible because they're already there in your care. So that provided us a way to maintain a community center that provides all of these services. And the thing now for us is, as Mukta mentioned earlier, resources are finite. How do we ensure that, we continue providing all of these services and doing what we love? So what we have explored in the Philippines is that, there's national insurance, and our national insurance provides a comprehensive package for people living with HIV for them to support their care. So it paved a way for us community-based organizations in terms of our sustainability, in terms of how do we now fund the things that we do, the things that we want to, we love to do to the communities, and also helping out the communities that we want. Because as an organization from our name, Love Yourself, how can we help others if we cannot help ourselves? We need to love ourselves further so that we could share the love to other people as well. So I think the lesson that we learned as an organization in terms of providing services is, aside from your anchor in providing the services for the communities that we want to serve, we have to ensure that you also have the resources to help. And ensuring that process of establishing where we are today, it's not an easy road, especially for, I would say if there are community-based organizations who are listening now in this webinar, it is not an easy road. But I think what we need to ensure is that you have an anchor, and from that anchor, we realize what are the things that we need to offer, what we need to set up, so that we will be able to provide that safe space for our communities. And as we build also that safe space, we have to ensure that we have approaches that we ensure that our services reach to the target markets that we want to reach. One size does not fit all, different strokes for different folks. So we have to also customize our services for the communities that we want to reach. And one thing, I guess, our advantage as communities, as I always say, we know the market because we are the market. We know the interventions that we will be offering as a community-based organization because those are the services that we also want to access. So I'll stop from here and I'll let the other panelists jump into the conversation.
That's brilliant. Thank you so much, Danvik. And really, it's clear from your recommendations that you start with what you know as a community group, and then there's this organic evolution based on the needs that you observe in the community. And yeah, as you said, you are the market, so you know the market best. I also really liked how you spoke to national health insurance, which Mukta also spoke to, right? And how important it is that it's not an either or. It's not public sector or private sector or KP-led organizations, community-led organizations, or the public sector. Co-financing can happen, and it sounds like you've been successful in securing funding through national health insurance for your work, which is absolutely brilliant and really the model. So Diana, I'd like to turn to you, just really thinking about, USAID's work in both primary healthcare and HIV and bringing those together. USAID's really priority for primary healthcare, including through launching Primary Impact, which is very exciting. And also your longstanding investments in HIV people-centered care share an important vision of strong commitments to enabling quality, last-mile care with a strong health workforce as the backbone. So what are some of the lessons that you've drawn while at USAID in investing in quality, people-centered care for HIV and what it takes? And what more needs to be done as part of integration and sustainability of HIV services? Over to you. Thanks.
Great. Thank you so much, Kimberly. And first of all, thank you so much for the invite to be on this panel. It's so great to be on with fellow esteemed colleagues. Really pleased to see this report launched off of the guidance that Mukta noted from WHO, which is something that USAID has been talking with WHO for quite some time. And, this discussion is so timely as the global community is really reflecting on the future of global health. We're continuing to think about and focus on restoring losses, of course, from COVID, and focusing on building resiliency as well for the future. And I think colleagues that are on the webinar today also know how over the past year, we've seen a lot of recommitment to UHC with primary healthcare as cornerstone. This was great to see within G7 and G20 commitments last year, hoping to also see that focus this year. And I think this is really just led internally at USAID, which is something that I want to talk a little bit about and share with you all today, around internal considerations for how we collectively contribute to primary healthcare across our respective global health programs. Of course, the launch of Primary Impact this past year, and just overall further thinking about how we advance integration and patient-centered care through our work. And I think when we look at the gains made in the HIV response, there's so many lessons learned. And I think we need the recognition of that beyond the HIV audience. And then on the other hand, simultaneously, as we're really thinking about within the HIV community about sustainability and what that means for HIV, we also need to have more robust consideration and consensus with the HIV community of what that means for integration, right? And PHC as being an important pathway for that. So first, just a couple of lessons learned, and I think some of this has already been underscored by the panelists in the presentation earlier, but what are really the lessons that we think about as the top lessons from the HIV response to date? Number one is configuring those service delivery models around patient-specific needs, right? So this HIV lessons around how we've been able to configure service delivery for women, for children, by different age groups, for key populations. This leads to quantifiable impact. It saves lives and it prevents new infections. So this, I think, underscores our top lesson learned. Secondly, community-based services plays a critical role, not only in extending services, but for HIV, notably as a chronic and a continuous service that needs to be provided through someone's lifespan. That important aspect as it relates to having that strong linkage and referral for patient follow-up. Of course, a lesson from the HIV response is the important role of robust civil society engagement, not only in advocacy, policy change, but decision-making and monitoring. And then, of course, I think we can't forget the important role of having sufficient systems and workforce, right? PEPFAR success really demonstrates the importance of having strong systems and adequate workforce. And this is something that we need better, I think, understanding of, recognition for, and how that also, I think, guides our investments moving forward. On the other hand, when we look at what more needs to be done to drive integration and sustainability, I think just to note how it's important to recognize how far we've come and how the landscape for HIV treatment and prevention has changed dramatically over the past 20 years. Very much thanks to PEPFAR's investment and leadership and advocacy, but treatment for PLHIV is now broadly scaled. It's substantially simplified. It's less burdensome to clients and to providers. And then also, I just want to note, which I think it was alluded to earlier, but it's important to recognize there is this ongoing debate, right, around how to really advance patient-centered care further. And does that mean that we add services onto HIV? Does it mean merging standalone HIV services with other services and structures? This is a healthy debate, but it's one that we need to continue to have. And I think internally within USAID, an important data point for us has been looking at our current PEPFAR footprint. And when you look at that, the substantial amount of PEPFAR-supported facilities are designated at a country's primary healthcare level. And this includes the community-based services that are either an extension of those facilities or a standalone, right? But also very connected to that infrastructure at that level. So this really is providing us a great framing for how we're thinking about those next steps for HIV and PEPFAR program sustainability. And I have just a couple of summary points. First, I think something that's guiding us is that there's recognition that we need that careful integration of HIV with other essential services delivered can maintain and improve patient care. Whether it be addressing comorbidities for an aging PLHIV cohort, managing hypertension as an example of that, how we're through integration are able to enable meeting more comprehensive health demands and expanding the reach of HIV services, including for those most at risk and underserved, thinking about key populations and even adolescents as a growing group across the globe. And then also how this will enable us to further reduce stigma and discrimination over time. I think a key thing that we also recognize, and this is important, I think, to have more dialogue on as well, is that service integration should not be just limited to services delivered and run by government, right? I think the HIV response has shown us the important role of CSOs, the important role of private providers, and these are the outlets that are also serving those that are most marginalized, and that they need to be part of the integration dialogue. So not to just focus on what is being integrated into a formal government-run system. And 2 summary points, I think my biggest takeaways if from my remarks are, I think to do this, we need to have a consideration for how HIV services are aligned with host country priorities for where services are delivered and what is delivered. So the where and the what. And the what also is what is delivered in the same setting, at what point of time, to meet that population and person-centered specific needs. We don't have all the answers of what that looks like, but I do think we need to establish those shared principles of understanding of what this kind of means in terms of guiding our work forward. And then, of course, as a systems person, as a health workforce person, it's just so critical to reinforce service integration also requires putting that equal emphasis on systems and workforce. Because if we don't have more focus on that, then it will be challenging to sustain, and it will be challenging to not have a country-led response over time. So thanks so much, and look forward to more discussion.
Thanks, Diana. That was so rich and so interesting. I mean, I think you laid out, really so many of the learnings, the proof points from the HIV response that can and should be used in thinking about how to scale up access to integrated people-centered primary healthcare and universal health coverage overall. And I just think about NCDs and how it is still such a struggle in so many countries to ensure coverage and access for diabetes, for hypertension, and whereas for HIV, it's an amazing success story of treatment. And what can we take from the learnings in HIV that could potentially be useful, different diseases, different contexts, but still there are ingredients that would be useful. And also really found it important in your points around, the what and the how. And, as I'm thinking about Dr. Salim, who's just joined us from Kenya with the Ministry of Health, he's thinking about, I think, the what and the how all the time, about primary healthcare, about the HIV services, which are known for their innovation and their integrated person-centeredness. So Dr. Salim, thank you so much for joining us. Kenya has been really at the leading edge of HIV, as I've just mentioned, really thinking about different innovations, community-based services, those led by the government and the private sector, and primary health care, and is really committed to integrated care as the foundation for strengthening its primary health care system. And just as also a side note, is also part of USA's primary impact initiative. So it'd be wonderful if you could tell us more about how Kenya is financially enabling integrated HIV and primary health care services by aligning domestic and donor fund investments. And also, if you could speak to how you're doing this through the primary healthcare network approach, which is really interesting, and I think participants would value hearing about it. Over to you, Dr. Salim.
Thank you very much. I really appreciate the invitation to participate in this webinar. I also want to appreciate the previous speakers for the elaborate information on this issue of integration. I think basically for us as a country, we are looking at integration. One, we are looking at UHC broadly, and how we can have integrated, comprehensive, and community or person-centered health services. More importantly, the government is looking at using the primary healthcare approach into achieving UHC. So for us in the country currently, especially the current government is looking at how we implement PHC. And just briefly, we have selected the hub and spoke model where we're having our primary healthcare networks that is using, in our Kenya system, we have 6 levels where we have level 1 as the community level. We have level 2 as a dispensary. Level 3, we have our health centers. Level 4, we have our primary healthcare referral facilities. Level 5 is where we have our secondary referral, but more importantly, in our devolved system, we have what we call our sub-county hospitals and the county hospitals. And then level 6 is the highly specialized services where we have very specialized services. Basically, the alignment in terms of financing what the government currently has done, we actually have a financing model looking at this different level. For level 1, level 2, and level 3, we'll be using publicly financed money to service or to pay for the health services that are given by the health centers and at the community level. From level 4, which is actually the hub for the primary healthcare networks, where it links with the spokes. The spokes include the level 3, which are the health centers, level 2, the dispensary, and level 1, which are basically the community health units. So in this level, we have what we are calling now the Social Health Insurance Fund. And we are glad that the president last year actually assented to this. He signed an act on this. Then from the level 5 and level 6, we'll have what we are having, or we are calling the Emergency Chronic and Critical Illness Fund, which will also be government from the treasury of the government. So there are 3 funds in one that will be taking care of people in the health system. And the 2 of these, the primary healthcare fund and the emergency and chronic and critical illness, will be actually government funded. So the social health insurance fund, which will be taking care of more of the inpatient services. This is what all of us in Kenya will be contributing to so that we can get health services. We are having this fund as something that can be contributed to by other players, including private, including donors, including the faith-based, so that it can be all-inclusive and we can have more contribution. But more importantly, some of the major changes that currently we are having, so that we can be able to integrate some of the other services, especially which were led by the private sector. In the current system, the private sector, the faith-based and the public will actually be given an equal footing, so that whoever provides services will be paid by this fund. So there'll be no discrimination. I think for us, we are looking at how we can actually move away from most of our vertical programs, including HIV, so that we can have, for example, in terms of the different scopes that we need to integrate. What are we looking at? One, the education level, from even the trainings, the institutions that are training. How can this be put that people, the health workforce, the system should ride on each other, should actually benefit from each other, so that they can work together. Then also at the planning level, we are looking at how we put different programs together during planning time, so that they can implement. More importantly, if it can lead to policy change, so that we can have health workers being more trained to cover more areas. We can have, for example, physical sites. We have seen in some of these primary healthcare networks where we have, for example, dispensing of medication or drugs, where, for example, it was initially just HIV, but the ART drugs, but now it is also used for the other dispensing of other medication, or where it was not being prescribed or being dispensed. How can it be dispensed? So in some of the hubs and spokes. Actually, these have been integrated. Some of the comprehensive centers are looking at integrating other services, but also, for example, the youth-friendly, integrating HIV program. So there's a both of riding on each other, also based learning. We know some of these vertical programs like HIV had very good data management. They had a very good mentor system where we could actually learn. So looking at the strength of either side and how we can actually put them together. The other issue on the implementation, we're also looking at having one or uniform monitoring and evaluation tools so that they can all integrate the same issues like supervision, where they're integrated, and more importantly, the health workers, especially for us in the primary healthcare networks where we're having the multidisciplinary team, bringing different teams to work together so that they can actually deal with the priority and needs of those counties. And more importantly for us at the community health level, our community health promoters currently, they are not trained vertically. For example, we used to have just community health promoters trained for HIV, for NCDs. So we had a very vertical silo training for our CHPs. Now we have a whole curriculum that it is integrated so that they're trained on all areas. And when they go to implement in the household, they're actually looking at the household as a person-centered, not as a vertical program or has a particular disease. And also some of the things that now they're supposed to do, they're integrating other conditions. They're not just being trained, for example, to do an RDT for HIV. So I think basically in terms of alignment and financing, that is what currently the government is doing. And we are glad that most of these financing models are being put into legal mechanism. So we have several acts. We have the Primary Healthcare Act, we have the Social Health Insurance Act, we have the Digital Act, and we have the Facility Improving Financing Act that are looking at improving the financing at this area. More importantly, we hopefully that we'll use a centralized digitalized system to enable this integration and comprehensiveness from level 1 to level 6. Thank you very much. Back to you.
Thanks so much, Dr. Salim. There's just so much that's happening in Kenya that is really a lighthouse for many of us in really understanding how to think through integration, how to think through the integrated financing you're doing, but at the same time, not lose the focus on specific populations like young people, key populations, people living with HIV, who may need to access services in different ways. And I think that multidisciplinary team, the network approach to PHC is a really interesting one, and many of the other examples that you offered. So really look forward to seeing the results in the next months and years of the work that you're doing and how that can inform the work in other places. So related to that, you spoke to community, Dr. Salim, and I'd like to now turn to Lillian. Lillian, ICWEA has been a powerhouse in community-led monitoring and keeping service providers accountable for high-quality services that reflect the needs, preferences, and values of the communities that they serve. Where are investments needed to further enhance CLM systems and effectively support communities to be included as essential partners in all aspects of health, including governance, planning, monitoring, and service delivery, especially as HIV services are now being increasingly integrated into and through the entire health system, and particularly primary healthcare? Over to you.
Thank you very much, and hi everybody. So when we talk about community-led monitoring, and when we put it into the context of the conversation today, but also in context of integration, we are talking about communities that are beneficiaries of services, participating in ensuring that the services that they are receiving are accessible, are available, affordable, but most importantly, that they are of quality. And therefore, community-led monitoring is about empowering communities to be part of the processes of service delivery. And what we mean here is that they are not only looking at the end, but they are participating in all processes of policy development, program development, funding mechanisms to ensure that what gets funded is what is needed by the communities and the end users. And lastly, but not least, to ensure that the implementation framework takes into consideration the needs and priorities of the communities. So that is what CLM is about. And that's what we've been doing, challenging at different levels to make sure that it is not just about coming up with programs. It's not about coming up with resources, but it is about what are the priorities of the people that these services are targeted at. If we talk about integration, for example, CLM is about getting into evidence to see how is integration working? What are we talking about, or what do we mean by integration? That it is not only integration that is looking at the end, but it is also looking at, are our policies integrated? Are we integrated at the funding level? Are we integrated at programming? Are we integrated at all these levels, so that when it comes to implementation, we are not just questioning how implementation is being done, how implementation is not taking into consideration all these issues, but that it starts from up there. So that is what CLM is about. And in terms of then what is needed, we've said that community-led monitoring is about communities. It is a process of collecting data, information, evidence by the communities, by the end users, on how they see these services, on how they see programs, so that they use that evidence to engage at different levels, so that they are able to change policy, programs, funding, decisions, as well as implementation. But what we are seeing in terms of what is needed now is that we are saying let communities lead in getting data, in informing all these processes and levels. But we are also seeing that the investment does not match the need. Because when you talk about communities, you must invest in the community so that they are able to do it well, so that they are able to be able to present quality data that speaks to the needs and priorities where these services are delivered, but also around the policies that the countries are using. So the investment is not as it should be. And secondly, we also see that there's a gap in terms of who determines what investment. If this is about communities, if it is about community-led, and if it is about communities taking lead, then they should be the ones to determine what investment is needed to give them the best outcomes and results. This is not what is happening. And then, of course, we are also now getting a challenge in different parts of the world that community-led actually is being done by different stakeholders. It should be communities, but in most parts of the world, it is different. It is either civil society organization, it is also governments are fighting to do community-led monitoring, and therefore it ceases. And then lastly, but not least, I'm mindful of time, is that when you talk about community-led monitoring, you're talking about a system that is going to be able to capture information, to capture data, but also that this data is not going to be doubted, and therefore it should be complementing or feeding within the national, regional, and global systems. And as of now, we don't have enough investment in ensuring that we build resilient, efficient data systems. So that's what I can say in terms of what the gaps are, but to say that it is an opportunity for us to be able to use and work with communities to make sure that at the end of the day, we have comprehensive services that are integrated and that are addressing the needs and priorities of the end users. Thank you.
Thank you so much, Lillian. Clearly, CLM needs more resources and more investment across the board. But thank you for your leadership. And I want to thank all of the panelists for your brilliant remarks. And with that, I want to turn over to Chris Collins, who's the Executive Director of Friends of the Global Fight, who will be leading us in a call to action. So over to you, Chris.
Well, thank you, Kim, and thanks to all our speakers. This has been a really fascinating discussion, and we want to stay in touch with all of you and just be part of continuing the movement on integrated person-centered care. I heard many really important things. I'll just summarize a couple, but it's clear that we have experience here with really providing excellent services, high quality services to people. We have a road to walk down now to make sure person-centered care is more available in the HIV space, and that we also look for opportunities to build out from HIV services to broader health, but also to integrate HIV services in a way that maintains the quality. A lot of themes. We need more investment in the HIV response and broader health, including health workers who are empowered and supported in being broadly engaged in health services. We need to be really intentional about how we expand person-centered care in HIV. Diana talked about integration being not just for governments, but also community providers and private sectors, and the importance of HIV services being aligned with country priorities. Dr. Salim talked about the need for clear planning and thinking about the policy change you need to make this work, and bringing multidisciplinary teams to the table to figure out how to make integration work. We clearly need to be thoughtful about how we think about building out from HIV platforms, being incremental about it. One size does not fit all. Different health systems and social contexts are going to mean building out from HIV needs to be done differently in different places. Community services and community engagement was something everybody pointed to in terms of that being essential in person-centered care working, but also in expanding it. Lillian talked about, she really emphasized quality and the need for community-based monitoring to achieve quality and maintain it. That system needs to be well-funded, and community-based monitoring needs to be integrated with national data systems. And to remember that, as we all know, building trust is so essential. Community monitoring can help do that. Measuring and improving quality, and absolutely, Mukta and Danvik talked about protecting key population, tailored services. We know what the market is because we are the market is a great line coming from today's session, and it's all about people in communities providing care to help. Let's stay in touch. We welcome more input and any thoughts that you have, but let's all be part of keeping the movement going. And there is contact information in the chat box right now if you have further ideas to share. Again, I want to thank everybody who has been part of today's session, and particularly our fantastic speakers. Thank you so much.
Thanks, everyone.